Hello and welcome to Conversations with Dr. Bachner. Once again, it is Howard Bachner, Editor-in-Chief of JAMA. And I'm joined today by Kay Gutenpale. And Kay is the Francis K. Friedman and Oscar Friedman, MD, 36 Endowed Professorship, Chief of Medicine and Pulmonary at Baylor College of Medicine in Houston. Welcome, Kay.
Yeah, thank you. Thank you for having me.
Oh, it's my pleasure. Thank you for taking the time. But before we start, I want to mention to our listeners, I do these live streams a couple days a week, and I have just tremendous support. And I really want to acknowledge Eric Butkus and Jesse McQuarters, who make these live streams possible. And I don't think in the past I've really thanked them appropriately. So Eric and Jesse, thank you. So Kay, you've been a physician, a critical care physician in Houston for many years, and we'll talk about some of the other challenges that you face there. But Texas is on the front page of the newspaper every day. What's it like in Houston? How large is your ICU? How many physicians are working in your ICU? What's it like?
We have at Baylor College of Medicine several hospitals, and we have 2 public institutions and 2 private hospitals. And I'm at Ben Taub General Hospital, which is a county hospital. So it's a public institution. It's part of a Harris Health System, which is a safety net hospital system with 2 hospitals and several community clinics, like 22 clinics. Interestingly, our hospital and the next door hospital, which is a Memorial Hospital system, we are the only, literally next to each other, but we are the level 1 trauma centers for the entire city of Houston. So we have several ICUs in our hospital, about 70 to 80 bed ICUs, different ICUs, MICU, CCU, SICU, cardiothoracic, and so on. But the medical ICU is 16 beds. We can go up to 20 beds. Usually we run a census of about 18 to 20. If you're asking how it is now, we have really surged. Since the beginning of June and maybe mid-June, there was a huge surge in the number of patients. So we have had a plan, like all the hospitals do, both at the college level as well as the hospital level. And I would say we are at surge level 3 as far as, increase in the capacity, as far as the beds and personnel and so on.
Do you have some reports about availability of testing? Now, if people are in the ICU, they're already critically ill, probably less critical. But when New York and Connecticut, New Jersey faced the surge, Massachusetts, some other states, I'm in Illinois, there were concerns both about PPE and sufficient numbers of ventilators. Has that been an issue for you all in your intensive care units?
I mean, fortunately for us, we've had a very good lead time. So we knew something was happening in China, but somehow it wasn't very close to home. But then Seattle happened and New York happened, and we really got geared up. And I must say that in being in Houston, we are used to having these, natural disaster crises that we face from, fairly at regular intervals. At least we are prepared for it, whether it happens or not. So we quickly gathered our forces and, all the same type of preparations we do. We know that it's a little bit different. So I think we have had no problems with PPEs, maybe initially a little bit in some hospitals, but otherwise no. PPEs have been good. Ventilators have been good. In our hospital, we have a capability of 110 ventilators. So we are running about 30 or so. So if we take anesthesia ventilators, we can go up to 135. If I add non-invasive ventilators, you can give some support. So I think ventilators won't be a problem, at least in Texas Medical Center.
Now, when you go home every night, you're in charge of the ICU. Do you worry about your staff? How are the staff doing?
I always worry about my staff. I think that's a very important responsibility we have, whether it's a surge time or not surge time. I think that, initially there's anxiety for all of the staff. both physician and whoever is around, even the environmental services that come and clean your bed, have these anxieties. Very understandable, because we don't understand what's going on. There's first anxiety, then there is acceptance in my observation. Then there is adaptability. They adapt, and then they excel. So that's my observation. So similar things I've seen for HIV in the 80s. Once they know and they've taken care of some patient, it's not so unusual. It's the same critical care. You just have to be careful. And then, we didn't see too many healthcare related transmission, although there have been small clusters, but not really in the ICUs. So whether you are at home or at work, you do worry about I think that's the highest responsibility that anybody who has been around all these people who work so hard and have younger families, when they're going home to a year-old, 2-year-old, these are the, nurses are young and they have young families. So they do have anxieties, but I think they have settled down now.
Okay, the epidemiology has been well defined since February or March. Now, it may be changing, and people have been very struck by that. The mortality rate, given the number of cases, is lower than it had been previously. And most of the people in the ICUs who were dying were in their 60s, 70s, and 80s. Is your ICU filled with people who are in their 60s, 70s, or 80s, or are you seeing younger people in the ICU?
I would say generally in our hospital, we see a slightly younger population compared to other medical center hospitals. I would say today we have about, not in the ICU, but the hospital admissions, about a third or less than 40 years old. So, some of them will deteriorate and come into the ICU, but I would say in general, we have a slightly younger population than an average hospital in Texas Medical Center.
Over the course of doing these live streams, treatments changed. It's been interesting. We were waiting for some information about the antivirals, remdesivir. We were waiting for some additional data about convalescent plasma. Then recovery was announced last week, and there's still some controversy about who should get steroids, who shouldn't get steroids. So how are you thinking about current treatment? Antivirals, steroids, convalescent plasma. As more data has emerged, how are physicians in Houston thinking about current treatment?
I think that's something that has changed since the trial with dexamethasone came out of England. I think that's one thing that has caught on quite rapidly, in my opinion. Before that, we were giving Solimedrol in certain cases and so on, but I think this has caught on quite rapidly. Having done this for several decades, I can recall 2 studies that after a single study, it has caught on. One was goal-directed resuscitation, goal-directed therapy, and another after single studies, tight glycemic control. And people change their practice but I think this one is different because we're familiar with the drug, we have used it, and we don't have that many side effects. And also the side effects, we know what to expect. It's not like some other drugs maybe that we are trying, like antivirals, that we're not so familiar with. I think we're familiar with this. So I think that the one that has made a difference in the last few weeks, I would say, is the dexamethasone for patients. If they're requiring any supplemental oxygen or their oxygen saturation is less than 94% on room air, they're considering getting dexamethasone 6 milligrams that they recommended.
And have you been utilizing the prone position or not as much as other places?
Oh, we use that a lot because ECMO is a very expensive proposition. It also ties down a lot of resources. So although we have done that on a couple of patients, prone works well. And I would say in all these years, maybe we would do like 7-8 patients a year of proning. Now I have 14-15 patients who are being prone. And although they talk about different phenotypes in ARDS and, All of those have been described. But I think the principles of treatment and management of ARDS, I mean, we just have to use our clinical sense and use the same principles. So I think proning is big. What I have seen new in this epidemic is a self-proning or cooperative proning. Right. People started saying, why wouldn't it work if you're awake? I mean, why do I need to have a paralyzed ventilated patient? So I would say it's working. And the only difference here is the ARDS patients that we saw before compared to COVID, these patients are staying, the length of stay is very high. You know, they're staying in the ICUs for very long. So the number of proning sessions is also high. So it is quite labor intensive on part of the people that are proning the patients. And also you have to be, I mean, paralyzed patient is you have to take a lot of responsibility for the patient, make sure that, you know, you're turning the head, make sure that the tube stays in place. And so I think it's increased risk procedure, but I think it works. And we have been using quite a bit, both self-proning on the floors, in the ICU before they get intubated, some of them don't, or on the ventilators.
Yeah, your observation about longer length of stay, I've heard that repeatedly over the last 3 or 4 months. We'll see the data, and we've published some of it in JAMA. Whereas I think in the past, patients with ARDS, you know, 6, 7, 8 days in the ICU. But now it appears as though people are 6, 8, 10, 12, 14, 16 days in the ICU.
Yeah, my length of stay is about 12 days.
About 12 days.
It used to be less before. One of the things that has helped actually to, you talked about safety of the, you know, healthcare workers. One of the things that helped that we implemented is, of course, we have all these protocols for self-proning with all cartoons and, you know, because we're using it so much in units that are not traditionally have not used it, like surgical ICU and other places where we are boarding these patients. Is the proning teams, which has caught on quite a bit in the medical center as well. We didn't have the need for it before. We may have a patient or two in the whole unit, and, you know, rest of the personnel would come and help. What has been wonderful is that the operating rooms are not operating as much. So we had like 4 people that have been assigned to the ICU from 7 to 3 and 3 to 11. It's such a luxury, and it's such a burden off of the bedside nurses, because now they can just direct it, and the operating room personnel, they do prone surgery, so it's nothing new for them, you know.
Nothing new.
They do prone surgeries.
Well, I don't think I've ever been prouder of the discipline of medicine and all of healthcare. People have really rallied to take care of patients, and, you know, your description of a new team moving a surgical team to your ICU so unburdens your staff, and they're so good at it. You know, you develop expertise. It's what you want to hear about kind of the learning healthcare system that we always read about. It's not so easy to do. Kay, you've been at this a long time in Houston, previously in Pittsburgh. What's unique about this pandemic? What's unique about this virus?
I think what's unique about this pandemic compared to your HIV threats and Ebola scare, which didn't really pan out, is that this is the first time when we are seeing that the same disease is filling the whole hospital. I remember maybe H1N1 time, we had at one day, we had 36 patients for 16 beds. That was just one day, and maybe it was there for a few days, maybe a week or 2 weeks or something of a large surge. But here we have the entire hospital, like New York's, and even in our place, like 100 patients are in the hospital that have one disease. Second thing is, when is the last time we have seen that some of your friends are affected? I mean, not because they had an MI or gallbladder or something, they are affected by contracting it, you know, either from community or from work or one of those. And the third thing is, you know, when is there a crisis, a medical crisis, that you wanted to volunteer, but you couldn't because you were needed in your same place. I remember when we had Harvey or any of those, I had friends calling me, can we come and do something for you? And they did come and help, But here, I couldn't send our people to New York because we don't know when we're going to surge, or if they contract disease and come back, how are we going to manage? So I think there was some of those unique. And when did we see the sports arenas become hospitals?
Yeah.
Or Central Park or any of those. I mean, I think this is one in a century occurrence, and in some ways, I think being a central part of this, I think we should be keep our eyes open for all the observations and really look back. It's not just treating patients. There's a lot going on at so many fronts. I think people who have been doing this for many years, look at the interns. They were medical students June 30th. Today they are interns. They are managing this surge. Amazing professionalism. I'm really, like you said, I'm so proud of every service,
There's lots of questions, so let's go through some of them. There's been a kind of frustrating, I think, for a lot of people about masking, and it really seemed last week Dr. Fauci, Dr. Redfield, NIH, CDC, and even some of the Republican leadership really began to say, it's time to mask. When you go around Houston, not necessarily in the medical center, are you seeing more people wearing masks, particularly inside? Do you have a sense of that yet, Kay? I don't know how much you've been out of the hospital.
I have been out of the hospital. I didn't get out of the car, but sometimes just to, get out of the same scene, I would drive around to maybe Galveston or something, which is not very far. But it's amazing that around Memorial Day and some other places, still people are not masking. It just worries me that they still don't understand how bad it is. And then, I saw somewhere that we are really tired. Please wear your mask, because just to keep up, we have to, they have to cooperate as well. So I'm not so sure if the extent of what can happen has really hit the public,
Yeah, I still worry that the message isn't clear, that masking protects other people. It may help the person a bit who's masking, but it really helps the people around you. And it's been an extraordinary number of deaths. Sometimes we just think of it as a number. It's 135,000 deaths. It's more than the entire Vietnam War. And I think we will easily reach 150 to 175,000 deaths before this is over. And I just wish the message had been clearer from the beginning and better accepted. Testing has come up. Is testing readily available for people outside of the hospital, or is it still difficult for people who are either asymptomatic but were exposed or are symptomatic to get tested?
There are several testing centers, and I know that some of the friends that I've had, they had no problem getting testing. In the hospital, there's no problem. We have 4 or 5 runs every day,
We're just beginning to see some reports. Now, it's earlier in Houston, so I don't know yet, but we're just beginning to see some reports that not only is the stay in the ICU longer, but the recovery appears to be longer, particularly for the elderly. Do you have any instincts about long-term morbidity? Is it different for this type of ARDS than it would have been for other types of ARDS? Or do you not have a sense of that yet? But people are increasingly concerned about long-term compromise.
My guess is, I think the longer you stay in the ICU, the longer you're paralyzed, you're on a ventilator, you're prone, and you're receiving all these sedatives and neuromuscular blockers, I suspect your recovery is going to be longer as well. And I'm sure there will be, people know about the post-ICU syndrome. You have like cognitive defect, you have psychological problems, as well as neuromuscular and other physical issues. So I think that it will take a longer time to recover. And anecdotally, some of the people that I know who have gone through this for extended periods of time, they do have a longer time to recover. So I think that we're going to, somebody it will be a study, post-ICU syndrome on all patients.
A lot of questions, interestingly enough, again, still about treatment. So off-label use of heparin, inhaled budesonide. Are you seeing much of that, or is largely your group staying with steroids and the antivirals?
We are staying with steroids. We use, remdesivir. And we are part of the study with remdesivir and tocilizumab, so that's the situation that we give that as a combination. We know that patients are hypercoagulable, and this is something quite unique that patients, all of them get prophylactic, heparin when they come into the ICU, prophylactic anticoagulation. But we are seeing a lot of pulmonary embolism and a lot of catheters that get blocked, like hemodialysis catheters, central venous catheters, even ECMO catheters getting blocked. So in those situations, in some of the hospitals here, including ours, if they see a high D-dimer or we're seeing a lot of clots of the catheter, access catheters, we are therapeutically anticoagulating these patients. Is that the right answer? I don't know. I know some of the hospitals are not, unless the patient has actually DVTs and PEs. But in spite of full anticoagulation, I've seen pulmonary emboli on these patients. In spite of that, still, having hypercoagulable manifestations.
Any other unique clinical observation? You have so many years of experience. You're seeing lots of patients. Any other unique observations that you think are different for COVID-19 versus ARDS from COVID-19 versus ARDS from other etiologies?
Something where right from the beginning, I'm sure you have heard this too. Something from the beginning we have seen is that the patients are very hypoxic.
Yes.
But they're looking at you. I mean, we have this WhatsApp group. This physician writes, saturation is 70%. Patient is talking to me, looking at me, and that is something very interesting and very unique. So, I mean, you see them that but then they crash on you. That is something very different, and sometimes you can't predict which way they're going. I mean, I was just in the ICU this weekend, and this lady, 80-year-old, but very functional, looking at me and starting 70, I want to, intubate. Then respiratory therapist says, why do you want to do? She's so comfortable. 4 hours later, she ended up getting that. So I think in spite of all these years, that something is very interesting to me as an observation, that these patients they don't look bad, and that may be kind of sometimes a false sense if they really become very tachypneic, although especially younger patients, they may have a lot of reserve. I mean, people have described PCL or patient self-induced lung injury. So just because they're breathing on their own, still the oxygen toxicity is still the same. You're breathing 100%, 80%, 70% with a high flow or non-rebreather. So there you're still getting oxygen in. So it's not like people don't get as excited when they're on spontaneous breathing than when they're on 70, 80, 90% on a ventilator. If they're breathing, if they have worker breathing is very high, if they're breathing 20, sometimes we've seen that, then, if they're breathing like 500, 600, 700 tidal volume, they could be injuring their lungs and, just like any other volume trauma with ARDS.
Okay, so you go home every night, or most nights. Just to let our listeners know, this live stream was delayed because Kay was working in the ICU. So we couldn't do it on Tuesday or Wednesday because she was in the ICU. But you run a large ICU. You're responsible for a lot of people. So when you go home at night, what do you worry about? And when you wake up in the morning, what's the first thing you worry about? So when you go home, what do you worry about? And then when you wake up, what do you worry about?
I mean, when I go home, my husband is there. My kids are grown. They're out of the house. I want to make sure that I'm not giving it to him because I'm exposed to so many patients. Right. So I have never been fond of scrubs all my life. I enjoyed not wearing scrubs in the ICU. But when I go home now, I've invested in scrubs. So when I go home, I go straight to the shower and I don't enter the rest of the house. So I just want, and we've been practicing social distancing at home since March, since we've seen these patients. So I just want to make sure, and it's not just me. My colleagues and my nurses have very young families. I know some of the intensivists who have not seen their kids. They just do FaceTime. They've taken apartments near the medical center. I think very few of the public realize the type of personal sacrifices people are making because they just want to make sure that they're not infecting their families. So when I wake up in the morning, we have every day 7:30 an executive call with all the information that comes from. And I've been doing this for a long time. Like I said, in Harvey, we've had all these command and control reports, but I have developed a very healthy respect last 1 or 2 months, every day logging in. My God, just we are at the top of the pyramid, and then so many people are supporting you. I mean, people are talking about supplies. What did they order? Do we have enough? Are we going to get, they order some new company. It's not, it's not the right fit. Some of them are defective. And, just to keep the things going, and we just wear it, we just take it off. And all we have to worry about is, am I donning and doffing? Okay. But there are so many, whole group of people worrying about how to get it to you. So I'm worried, what is the number I'm going to hear today from the nursing supervisor? And that's been around 25, 30 for a long time. Suddenly we are hearing like in the 90s and 100s. So that's what you say, how am I going to make this happen? It's not just opening the beds, but it's nursing services worried about their personnel. I'm worried about I've already pulled my fellows from electives, from research, and, so we're still managing with intensivists and pulmonary critical care. The next step would be in some of the hospitals in the area had to do is with hospitalists have been pulled into the ICU pool with a critical care person as their backup. So they have been helping tremendously. Now we have recruited a inpatient hospitalist just to work in the ICU all night because the residents are so overwhelmed because of the number of consults and, courts and all of those that are going on. So I worry about how are we going to staff. And, now this week from Monday, I have they've been nice enough to give me a cardiology fellow to put all the lines for me because there are so many patients and, sometimes you're stuck for an hour and a half getting 2-3 lines in, anesthesia comes and intubates. So I think it's a group effort. I know that physicians and nurses are seen as a face of this pandemic for the general public, but I've developed a very healthy respect for a lot of other people who are working just to make this tick, and if they don't, we have no prayer, at the bedside.
Well, I was struck by your comment that relatively well prepared. As you said, you had weeks to think about it, but some of the supply issues that have been so difficult for other places in the country seem at least not to be as a critical issue in Houston. Do you have a sense of what the next week or two will look like? Hey, this is the last question. Do you have a sense of what the next week or two will look like? What have the numbers just been over the last couple of days?
The number of cases has been pretty steady, I would say, above, each hospital about 100 or so cases. We start getting excited between a day to day. I think we are kind of staying steady and we are preparing, like I said, because they don't get better so fast. So we have to prepare still to be able to take care of them. So we are prepared to expand more. And I think we still have some room at Texas Medical Center and in the rest of the hospitals. And one thing very beautiful here is that we have a huge peer group, both in our field and other fields. So I think the WhatsApp group that one of the Dr. Kanti started at the beginning, I would say maybe in February or March, We've had people from Bergamo talk to us, from China talk to us, from New York talk to us. So we've been waiting for this to come and land on us. And, we've been looking at this for quite some time. So I think that, we still have some room. And one of the things is we have learned, as we said, we make these protocols and we have all these calls, and it's like a support group as well, since we don't socialize so much. So at 2 a.m., I may get a text and somebody's answering. And that is the beauty or not so beauty. I don't know. Somebody's answering at 2 a.m. So it has been like I think in my opinion, I don't know, it's not very scientific, but it prevents the burnout. I think somebody who's in the outskirts in a small hospital, is saying, hey, somebody's 70% looking at me, and somebody else says, hey, I have the same thing. So otherwise, you didn't have that support. In 1 week, there were 400 posts, mostly clinical, mostly PPEs, mostly, yeah. Hey, what's happening, So I think it was very, very good for us.
This is Howard Bachner, and I'm editor-in-chief of JAMA. This has been Conversations with Dr. Bachner, and it's been wonderful to talk with you, Kay. Kay Gutenpali. Kay is the Francis K. Friedman and Oscar Friedman, MD, 36 Endowed Professorship for Pulmonary Diseases at Baylor College of Medicine. And as I said, Kay couldn't talk to me earlier in the week because she was taking care of patients. And I think through the last half hour, 35 minutes, it's pretty clear that she's really committed to taking care of her patients. And Kay, to your entire staff, the extended staff, and people in the hospital that help support you, I hope you can all stay healthy over the next coming.
Thank you so much.
Take care. Bye-bye.
Thank you.